Hello and welcome to the AHF podcast. I'm your host, Joe Schwab. For years, the conventional wisdom has been that hip resurfacing had its moment and lost it. My guests today think that story isn't over. Dr. Sharat Kusuma is an orthopedic surgeon who traded the operating room for the corner office and now leads JointMedica as its CEO. He's joined by Dr. Craig Della, one of the most recognized voices in adult hip and knee reconstruction. We're going to get into why they think resurfacing deserves a second look, what JointMedica is building, and what the road from surgeon to CEO actually looks like. So let's get right into it. Sharat, Craig, welcome to the AHF podcast.
Thanks for having me.
Thanks for having us. Appreciate it.
So you two have known each other, and correct me if I'm wrong on any of my history, since Sharat was a fellow on your service, Craig, almost 20 years ago. Before we get into any of the science of what JointMedica is doing or hip resurfacing, what's the first thing that comes to mind when you think back to that time together?
I think it was a day like today. We just had a big thunderstorm come through Chicago. And I think I took Sharat out on my boat at that point after the operating room. And it was a day just like today. It was like one of those days where it rained really hard. And then the sun came out. And I think we were in the playpen in Chicago. That's where I feel like is my first real memory of Sharat was taking him out on the boat, I think.
I'll share one more memory. Craig was obviously a little more junior at faculty at that time, and we can joke around as friends. I remember infections and a lot of doing those together, and times have obviously changed, right? But we had a good time. I remember going late 10, 11 o'clock at night frequently with the last case of the day being some disasteroma. But, it was obviously great training. So I do remember going through that. And of course the departments changed, but yeah, just we had a good time writing papers together and doing cases together, and obviously phenomenal education going through there.
So, Sharat, let's talk a little bit about JointMedica, because for those of our listeners who maybe haven't heard of JointMedica or are familiar with it only in passing, tell me the problem the company is trying to solve, and maybe a little bit about why that problem still exists after years of us innovating on total hip replacement.
Sure, and this is, by its inherent nature, the question you ask is a loaded one, because many will say there is no problem to be solved. Why do you even exist? And that's of course sort of the dilemma of trying to be an innovator, especially in orthopedics, but maybe in even medical specialties beyond that. The problem we're trying to solve is the following. And again, folks have different beliefs on this, but if you talk to surgeons like Craig, myself, during my clinical career, we have this assumption that I believe is a bit self-serving, that total hip is a perfect operation. Everybody's thrilled. Everybody's happy. Everybody's great. Everybody's has this perfect forgotten hip score, and there are no issues. And I think that's a bit of a narrative we probably tell ourselves because it makes it easier to not push for innovation. I hope that doesn't come across as, and so those of us who've done those, and I'll just kind of give you a little more context. Craig taught me how to do partial knee replacements as well. And this has been an age-old debate. And I haven't talked to Craig in the last couple of years about partial knee replacements, but similar to resurfacing, and if you draw the analogy between partial knee replacements and resurfacing, people with a well-done partial knee are a different animal than people with a total knee. And I've got patients of my own, and Craig was very influential on me in this regard as well, in addition to many others. Anyway, the problem we're trying to solve is giving people who are relatively physiologically young, I'll say, leave their numerical age aside, a hip that feels like they never had their hip done. And I my sense is that's not the case. Yes, total hips are great. Yes, total knees are great. But if we really sort of push ourselves for a perfect arthroplasty, a perfect joint replacement, I don't believe a stem total hip achieves that yet, just like I don't believe that a conventional tri-compartmental total knee solves that yet. So that's the problem we're trying to solve, is giving people function where they don't even remember which hip they had, and they just do everything they want to do without any thought of restrictions or anything. And that was my experience in my career doing resurfacing after I learned from Craig. So I'll stop and we can discuss further, but that's
Well,
what we're trying to solve.
Craig, I want to ask you, the problem that Sharat just described
Yeah.
is that the same one that you'd name from your own clinic? Would you frame it a little bit differently? How do you think about it?
Well, I think about it a couple ways. The reason I got interested in hip resurfacing was Aaron and Rosenberg and I were talking just as hip resurfacing was kind of hitting the scene. And we both came to the conclusion, someone at Rush should know how to do this. I feel like at a tertiary care center, one of the things that you do is you try new things. And I think a lot of surgeons make decisions about a new implant, a new technology, a new something without giving it a try. And I think it's hard to intelligently talk about a topic unless you've at least tried it.
Mm.
So the story is actually very funny. So I was supposed to go to Canada to go learn how to do resurfacing. And I got to the airport and it said, please scan your passport. And I'm like, you don't need a passport to go to Canada, it's just Canada. So I go to the next kiosk and they say, scan your passport. I'm like, what is wrong with these machines? I go to the desk and they're like, you need a passport to go to Canada. I'm like, when did that happen? They're like, Monday. I'm like, would have been nice if you guys sent me an email or something like that. So I missed my flight to go to Canada to learn how to do hip resurfacing. I then looked at my calendar and said, when am I going to go? And the only thing that really made sense was going over US Thanksgiving because I didn't have any surgery scheduled. And I'm like, cool, I'll go to Birmingham for Thanksgiving. And I met all the folks in Birmingham. And I love stuff like that. You know what I mean? There you have a bunch of people who are really excited about something and studied it so many different ways. So I basically went and learned how to do it. I'd scheduled 2 resurfacings for the Monday after Thanksgiving.
Mm.
And I'm like, let me do like 20 of these and kind of see how it goes. And I will be honest. So at the time that I was learning resurfacing, we were doing the 2 incision hip.
Mm.
So we were doing total hips through these little percutaneous incisions with fluoroscopy and all that other stuff. I felt like dirty. Like I'm making this giant incision, complete capsulotomy, all this other stuff. It was actually my nurse, Kim, who said, you know what, Craig, I think we should put our resurfacings on the 2 incision hip protocol. And we did that and the patient just did really, really well.
Mm.
So, I mean, I think there's a lot of reasons to consider hip resurfacing. One is, as Sharat had said, I mean, I think at the end of the day, I understand the viewpoint of a lot of orthopedic surgeons who say, this is crazy, this is ridiculous. Hip replacement's a fantastic operation. The durability is unbelievable. The complication rate is low. You're messing with something that is pretty close to perfect. And it is, but it isn't perfect. I mean, we still have dislocations. We still have periprosthetic fractures. We still have infections. And I would tell you, in my experience, we've never had a resurfacing dislocate, as far as I know. We've had one periprosthetic fracture. One of my patients was like on a scaffold, like a 3-story scaffold, and fell and got a subtrope fracture. And we've only had one acute postoperative infection that somehow healed. I thought for sure it was going to be a problem, and it healed. And maybe that's the patient population. There's lots of potential bias in there. But the patients do really, really well. And, I am very permissive with them. We tell them to start stretching at 6 weeks. We tell them they can start running a mile or less at a year. And at 2 years, and at 6 months, run a mile or less. At a year, they can do basically anything they want. And we've had patients do triathlons, marathons, super ultra marathons, Tough Mudder, Spartan races, active duty military, active duty firemen, and do like really impressive things. Now, there are those who would say, well, where's your randomized data that says they couldn't do it with hip replacement? Agreed. Understood. But there is something to it. And I think, like a lot of things, I just don't think we understand it 100%. Maybe it's the anatomic head size. Maybe it's not putting something in the canal. I don't know what it is, but the patients do really, really well and they're happy. And then there's also maybe a less popular reason to consider it is there are 100% patients who want an alternative to a conventional hip replacement.
Mhm.
And I have very good friends who say, yeah, those people are not right. And we could get them a psychiatrist to help them get over the fact that you're going to remove their femoral head. But 100%, and I'm sure Sharat, I don't know if you saw this in your practice or if you see this now. I'm sure you do. I'm sure you have people reach out to you, say, I don't want a hip replacement. I want something else. And that may be a bad reason to consider it because basically, for lack of a word, it's a marketing angle, you know? But there are 100%, there's a patient population out there who wants this. And at least for me, given the positive results I've had, and we'll talk about metal, I'm sure. Um, but even considering my metal failures, the patients do so well. I think for me, it's been hard to give it up because the patients do so well and they're so happy. And there's people come and see me all the time and want an alternative.
Mm. And so when you started on this journey, when you went to Birmingham, you came back, you kind of lined up, the next 20 or so hip resurfacings. Was that the same year that Sharat was a fellow?
It must have been.
Yeah,
Was it
Craig,
what year were you a fellow?
you for your very, very first. I was in the. We scrubbed in with you
Yeah,
for
so
your
it must have been. I mean, I
PhD.
went to Birmingham. I worked with Mr. McMinn. I
Yeah.
was just, again, I love stuff like that. I like history. I love people who are super committed to something. And, at the end of the day, is Mr. McMinn a controversial figure? Absolutely. Does he like being a controversial figure? Absolutely. But the guy's really smart. He's really innovative. And it's not like he's like casually interested in it. Like they did so many good studies looking at every different facet of the procedure. And I think for me, one of the things I think that worked, for lack of a better word, was I've seen enough variation in the way that people do operations that I said, these folks have spent a lot of time thinking about this. There's no way that me just learning how to do this is going to have some idea that's going to be better. I'm going to do it exactly the way he taught me. Exactly. And I literally, again, I went to the training and I came home that Monday and I did it exactly the way he taught me. I didn't vary anything because, again, they had good results and they still have good results. So I didn't mess with it in any way.
And
So
the other part of the
both,
story, just real quick, worth mentioning, Joe and Craig, is that we associate this with Derek, and of course, I trained with Derek as well after I left Rush and learned resurfacing. But there are lots of other, I'd say, good clinicians, good clinician scientists who believe in this. Even John Charnley, to go back
Oh,
to
absolutely.
research historically, the belief was always that resurfacing is sort of the default way to treat hip. And the reason it didn't work back in the 60s and 70s was not because the biology of the operation was flawed, right? It's not like the femoral head died or something. It didn't work because we didn't have materials in the 50s and 60s and 70s that could work. But I mean, we talk about Derek a lot. We all, of course, know Derek very well and respect him immensely. Lots of brilliant surgeons looked at this problem and said, wait a minute, why am I doing an intercalated amputation and chopping off this large segment of the hip? Let me try to do something else, so maybe perhaps slightly more elegant. And Joe, there's one thing as far as the problem that I think is worth commenting on, and Craig goes to all the meetings. There's a fairly big tsunami of periprosthetic fractures that is here, that's coming for patients who are in their 70s and 80s, who had hips done 10, 15 years ago. Of course, the Mayo published on it. That's a devastating problem to fix. And I suppose part of what was my motivation, I'm kind of pivoting back to the clinical side of my career when I was young, when I saw all the revisions we did at Rush with Wayne, Poprosky, and Craig and others, revising failed total hips can be a pretty destructive operation. And so, part of me being a young surgeon was I want to try to preserve as much native stuff as I can because fixing problems with more native stuff in the body is easier than fixing stuff when I put long, cementless ingrowth, and of course stems of, I get that, right? But we create, these are definitive when you do a total hip on somebody or a total knee on somebody, there's no going back. I mean, there's no, right? If they're not happy, there's nothing to do about that. So I think just the idea of being perhaps elegant in our treatment of these problems and trying to be as anatomy preserving as possible. And of course, our cardiology colleagues have thought this way for a long time, right? The way that things have evolved in cardiology, whether it's open heart surgery, pivoting to robotic, or, open valve replacement to, transcatheter valve replacement. So that's a little bit of I was thinking about your question, what problem are we trying to solve? I think it's multifaceted. But anyway, I'll let Craig continue on his the points he was making.
Well, so a quick question here. So that initial experience that you had with a few cases, then maybe 20 cases or so, you're doing most of these together. Was there a specific moment? You described, Craig, kind of some periods where suddenly you maybe had an idea that I'm going to do it this way. I'm going to offer it to these types of patients. Was there a specific moment for either of you when resurfacing went from an idea that you thought maybe should be an arrow in my quiver, so to speak, to the thing you really wanted to focus on and specialize in and become exceptional at?
I think for me, it was more, to be honest, arrow in the quiver. It was one of those things where, again, I thought someone at Rush should know how to do this, and offer it and study it and try to understand it. And I remember when one of the last things that Derek said to me when I visited him was, Craig, if you do this operation in young males with osteoarthritis, you're going to have good results. And even though, the implant had wider indications at that point, those are the folks that we stuck to, big, younger males with osteoarthritis. And I think that's one of the reasons why my experience was so positive with it.
Sharat, how about for you?
Yeah, I can share. So, and this is a pivotal moment for me, maybe slightly different than Craig's. Craig might remember this, but when we were at Rush, we had a couple of visiting kind of quasi professor. There's a guy named Andrew Manktelow from Nottingham, UK, who is an excellent hip surgeon, spent most of his career revising just absolute disaster, custom triflanges and ETOs, 5 a week kind of thing. He came to visit us at Rush during one of our joint conferences shortly after I was on Craig's surface. And I remember this, again, this is 2007, 2008, kind of at the peak of resurfacing. Andrew said, Sharat, listen, similar to what, and Andrew's not he's not he was not conflicted. He's not an implant inventor. He sort of had really nothing to gain other than, he said, Sharat, I see that you all are dabbling in resurfacing here. And similar to what the advice that Derek gave to Craig, Andrew said the same thing. He said, Sharat, this is a great operation. I've been doing it for 10 years now. I've done it in close friends and colleagues. And if you learn it well, it's a fabulous option. And so, and again, of course, Ronan Treacy, I met him along the way. I'd met so many thoughtful clinicians that are honest about reporting their results. When I saw what they were saying, I felt compelled, even just as a thoughtful thinking person, to, like Craig said, go to the place where they're doing it and make sure that the hype is either real or not real. And so after I left Rush, I actually spent 6 months in England and spent some time with with Andrew, Derek, and Ronan. And I was just amazed at what I saw, because I was able to be in the follow-up clinic, right, and see young active males who were 10 years out, that were done in 1997, that were coming in. And I was just, and I'd done clinic, no offense, I'd done clinic at Rush and saw total hip patients, and it was a different person. The guy who was 57, who had the resurfacing at 47, versus the guy who had a total hip at 40, they were different. The way they behaved and acted was different. And I saw it with my own, and again, I don't have the randomized data, but it was pretty compelling. That was my sort of 1 year aha moment over the course of finishing fellowship with Craig and Aaron and Wade, and then going over to spending extended time, seeing patients in the follow-up clinic that were many, many years out. It was pretty compelling.
Mm. And so, Craig, you kind of foreshadowed this a little bit, but I know a lot of our listeners are residents, fellows, and people who are coming out at a time when, maybe their understanding historically of hip resurfacing is that it's not a very successful operation, or it's had problems. So in the early 2010s, resurfacing's reputation took, kind of a real hit because of what you mentioned, partly getting caught up in metal on metal fallout. couple of questions about that. We don't have to get into the science per se, but you having spent time creating expertise in this operation, what was it actually like practicing through that period? And did your patient conversations change during that time?
I guess they did and they didn't. I think we were always a little nervous about the metal bearing. You know, my other senior partners, Josh Jacobs, who's one of the people in the world who knows more about metallurgy, bearing surfaces, and metal. And a lot of that came from, you know, George Galante, who had a big interest in the systemic effects of hip and knee replacement. Like when I was a fellow, all of a sudden I'd get a page and it'd be like, this is so and so funeral home. One of Dr. Galante's patients passed away, and you're supposed to come here and get their hip replacement. I'm like, excuse you. So they had a big interest in the systemic effects of joint replacements, and that's where they got the expertise in retrieval analysis and also measuring serum cobalt and chromium. So there was a lot of concern about the metal bearing. So I think I was always a little cautious regarding the bearing surface.
Mhm.
And, you know, I never did that many metal on metal hip replacements. Almost all the metal bearings I did were the resurfacings. So I never had like a, a large number of failures. And, you know, to my point, I guess a little bit earlier, there were certain resurfacing designs that had a much higher rate of failure, and the Birmingham didn't. And I think some of that was that, you know, the people, you know, around the BHR, I guess they had enough failures and they kind of figured it out and studied it. And either they made the right guesses or made the right choices. And the BHR, again, other than the metal failures, um, and even the metal failures with that particular implant, I don't think were as high as some other implants during that time period. So
Mm.
again, it's frustrating. And for me, and this kind of leads into how Sharat and I reconnected and why I decided to do the PolyMotion device, was it's frustrating when a patient comes in. I don't think anyone I don't think any orthopedic surgeon likes complications. I think if you ask most of us, that's the worst part of our job, is managing our own complications. You know, at the end of the day, you feel like, is there something I could have done different or better? And then this patient wouldn't be having a problem. I think that's the nature of the personality for someone who goes and says, I want to be a surgeon or an orthopedic surgeon. So it's frustrating when someone comes into your office and you look at the x-rays and you're like, yeah, I don't think I could have done anything different. And they've got a problem and you're revising them. So, I mean, that was and still is frustrating when you see that, because again, I don't mind doing revisions. I just don't like reoperating on my own patients because again, it pisses me off. You know, like, is there something that I could have done differently? I feel like most of the patients, we explained to them that there was a risk. And I think, you know, relatively quickly, we knew that there was a risk. But again, I listened to Mr. McMinn, and I did mostly young males with osteoarthritis, and my complication rate overall was low. And even in the darkest days when it started to be like, well, is there medical legal risk here, et cetera, et cetera? I just kept having patients come in who were happy.
Mm.
And it was hard to ignore the fact that these patients were doing so well and doing so much that I never walked away from it.
Mm. Well, and Sharad, so you described, kind of coming out of your fellowship and building a really resurfacing focused practice. And this would have been right as the field was kind of starting to sour on it. What was that like for you?
Well, so yeah, I mean, I left Rush and ended up joining another Rush fellow, former Ray Wazlewski in Columbus, and joined his practice. And so, as far as what it was like, I suppose I had a fair amount of confidence that the thing worked because, again, I had spent extended time, with it's like going to do the Oxford Fellowship in Oxford, or going to do the Karai Fellowship in Annecy, something like that. So I was very nuts about, like Craig, doing the operation exactly like every single retractor, right? Exactly the way that Derek and Ronan did it, the way and Andrew did it. And I just found that patients would find, and I didn't do it for marketing reasons. I thought it was a better mousetrap. And I guess I thought it, at that time, age 33, if I needed a hip, that was a hip I would get. So I should know how to do that hip, based on so the practice building for me was pretty straightforward. And like Craig, and again, I was very neurotic about every step of the operation, indications. I ended up having pretty good results. And the few failures I had, they were on me. They were my fault. I either anteverted the cup too much and had a little bit of edge loading. That's on me, right? I had the cup a little bit vertical, but the ones where they were, down the pipe, um, like Craig said, they were just unbelievably happy patients. The best patients I had in my arthroplasty practice, and it just kind of became this, in Columbus, Ohio, which is a decent metro area. People were coming, finding you from all over without any sort of marketing or anything. And I guess the other, I don't know, Craig, if you had this experience, but here's what I found most compelling. They were like farmers from rural Ohio, right? Who drive, and they said, "Hey, I heard about this thing, 65-year-old, and this is what I want." And this is not some, bougie downtown Chicago, lawyer these just people like, I need to make sure I can farm, and, firefighters again. And they had done the research, and I was like, that's very interesting that a person who otherwise would just sort of walk in, from rural Ohio would walk into a clinic and say, I've done, this makes sense to me. And they had heard about, they had a friend of a friend or something who had it. If it doesn't work, why does that keep happening? Why does that movement continue? In fact, what I find most fascinating about all this, and Craig, chime in if you disagree, what's kept resurfacing alive is probably the patient-to-patient word-of-mouth referral as much as because there's so much negativity around it. Patients who have it, and, these patients obviously, some of them do research. They tell their friends, "I had this." They meet the friend. I mean, that's what's keeping this thing alive. Surgeons want it to die for sure, take it out back and shoot it for sure. But really the public and the patients are what keep it alive. There's got to be something there because it was such a bad thing. Why would that keep happening? And I'd be curious, your both of your thoughts on this, but, those are interesting things, whether it's in, any kind of product, right? Why don't products die? Well, they don't die because they're solving a problem for somebody who's the end user. That's not any one of us on this call, but actually the person who uses the product every day in their life.
Well, and Sharat, you've said publicly that you don't see this product, the PolyMotion product, right, hip resurfacing, from JointMedica's perspective, as a niche product. And I think you've floated a number maybe as high as about 30% of hip arthritis patients being sort of potential candidates for this. Just plainly, where does that number come from?
Well, I don't know if folks would consider, a third a niche or not, but what Craig just said it earlier, young men who have arthritis, that's a pretty large segment of the population. You've got otherwise relatively normal anatomy, who don't have AVN, who don't have some weird, old, dysplasia or something like that. That's where that number comes from. Whether that seems high or makes me a nut job on your podcast, et cetera. But, there are a lot of young active males who have arthritis who are looking for this. So that's where the number came from, Joe.
Craig, does that match what you're seeing in your own practice, or maybe even in the IDE study that you've been doing so far?
I don't know. I mean, I think some of it may be selection bias or the fact that I do it bias because I get, people in my practice sending him to me, these folks specifically to me. I don't know what the right number is. I don't know what the indication was. I think, frankly, I think one of the things that limits it is it's hard technically to do the procedure. And again, I think metal definitely didn't help. So I think the combination of those two things limits the applicability of it. I think with the PolyMotion device, if the results are going to be as good as we think that they're going to be, because again, when I look at my own results, in my hands, the most common failure was adverse local tissue reactions from the metal and metal barrier. So I think if I take that away, at least for me, it's quote unquote easy to make the argument for the operation, but it's technically more difficult, and you don't get paid more to do it in the United States. You bill it as a total hip. So it definitely is. I don't think the casual hip surgeon, I don't think the surgeon doing 2 or 3 hip replacements a month. I don't think that's an operation that they're going to be comfortable doing.
Mm.
So I think it has to be for someone who's interested in learning it and, doesn't, again, I think it's like everything else. You get good at doing things. I think most surgeons who do resurfacing would say that it takes them a little longer to do resurfacing. There are some parts which are great, the cups monoblocks, so you're not putting in liners. And if you're someone who trials when you do your hip replacements, you save potentially a little bit of time there. And there's no trialing. Once it's in, it's in. Often, when I first started doing it, first couple of years, fellows would call me back to the room and they'd be like, it doesn't really feel that stable. I'm like, so what would you like us to do? There's no option. Once it's on there, it's on there. There's no modular parts. So it definitely saves you some time with that. But I think in general, it's a technically more demanding operation that takes a bit more time. And at the end of the day, I don't know if either of you saw the AUKUS newsletter the other day that looked at the proposed rates for total hip replacement. For Medicare,
Saw it. Yeah.
it's,
Race to the bottom.
we could have a whole other podcast about why I opted out of Medicare and what the experience has been. But at the end of the day, that's why. It's reached that point. It's less than $1,000 is what they're proposing on the national average for payment of hip replacements. So again, I understand that there's a barrier there for the average person who's doing it. And you look at an operation where I'm not going to get paid more and it's technically more difficult. It's definitely a barrier.
Can we talk about this this is an interesting dynamic. I don't know that I believe that the operation being technically more difficult is a good reason. And this is where you sort of mix the combination of the business side of running a company with being a clinician. Companies can make it easier to do operations, right? That's what companies should do. And so, there's a huge element of it as I've made this transition over. That's a solvable problem. And the fact that it hasn't been solved doesn't make it a bad operation. Just like if you look at the use, this will be a controversial topic again for another podcast about unicompartmental knees and robotics, et cetera. But I believe there is some data that shows that in lower volume, and Craig, you read the literature more than I have a chance to recently, in lower volume uni surgeons, using a robot makes it more reproducible. Whether you love it or hate it, leave that aside. Operations like this can be made easier. And so at least one of our passions is not just not to bring the implant to the market, but also to bring it to the market in a way where we make it easier to do that from a commercial, strategic, just being an industry person is just absolutely essential to the entire, it's not just enough to do the testing and bring the implant to market. You've got to make it where, and I just feel, part of my journey of what motivated me to do this is I think companies can do a better job of that, of making operations easier and easier and easier to do. And that, in fact, I think it's the responsibility of companies to do that. And we certainly believe that at our company and to one of our passions, in addition to bringing innovative devices to market. So.
Well, and we're going to talk a little bit about the, how you might be making it easier, but let's talk a little bit about the product itself. So a couple of questions for you, Sharat. I'm just going to give you some quick questions, almost sort of 30-second version of this. So first of all, the name PolyMotion. Tell me where it came from. And secondly, PolyMotion's bearing surface is really the distinguishing factor between it and previous generations of hip resurfacing, at least as far as I can tell. So what's different about the bearing surface from the systems that you trained on or that you were most familiar with going in? Explain to our listeners.
Yeah, I'll answer them in reverse order. Actually, part of what I believe, and Craig, you chime in here, what makes the PolyMotion implant attractive is that it's sort of the devil we know, and we know it very, very, very well, as a matter of fact. It's fairly vanilla in terms of it's a vitamin E, highly cross-linked polyethylene that a lot of the listeners of your podcast have been using for, 20 years or so. And then on the head side, it's a metal head, cobalt chrome, highly polished. This is a bearing surface that we sort of know when it goes south, why it goes south. And so as far as saying it's different than other resurfacing bearing surfaces, but part of what at least I don't want to make any marketing or regulatory claims because the products are not approved yet. But in terms of the facts of the device, it's a cobalt chrome, which we've been using for 60 years, obviously without a trunnion, on somebody's femoral neck with a vitamin E, highly cross-linked bear that is now almost ubiquitous in I don't know what Craig uses for his primary hips lately, but that's why I think one of the appeals of this is that it feels familiar. It's not some unknown, strange bearing surface. So that's the first. So that's what the bearing surface. It's a monoblock cup with a titanium, surface on the back. That's an ingrowth surface. As far as the name PolyMotion, I don't know that the orthopedic industry is going to win any awards for marketing the way that perhaps Apple or Microsoft or Coca-Cola do, but it was a name when we bought when I say we can talk about the financial structure if you're interested, but when we bought the company from the McMinn family, if you will, they had already named it PolyMotion, and I don't think they didn't hire IDEO or some top marketing firm to name the
You'd
implant.
have some kind of unpronounceable non-word that goes across 13 different languages.
But there's also one of
Cookie
those.
memes.
There's also one other little thought here is that remember BHR, right? BHR, PHR, just easily, it's sort of, there's a familiarity for those who are in the market. So those are some of the reasons where the PolyMotion, it's polyethylene. It provides a range of motion. That's where the name came from. But again, I don't think the name sort of will end up driving the success of the implant. I mean, my sense is if we make a good implant with good clinical results and we make it easy to put in, that's probably what's going to drive more success. But that's the story of how it came about.
Joe, could I push Sharat on something? And it'll help him in
Please.
the end, but he might not like me for 30 seconds. I would challenge you on one concept. I think when an orthopedic surgeon picks up that acetabular component, that is not typical. You know what I'm saying? Because it's basically vitamin E poly with beads on it. Can you talk a little bit, Sharat? Because again, it's one of the things that I guess being someone who was comfortable with resurfacing, comfortable with cobalt chrome, vitamin E crosslink polyethylene bearing, but the cup doesn't look so normal. So can you tell us a little bit about the clinical history behind that kind of cup? Because there's one there, but I wasn't familiar with it. And can you talk to us a little bit about the cones on it? The two cones
And I've
and
got
how that came up? Because again, I think it's unique, and I don't think it's that familiar to the average orthopedic surgeon.
I guess what I'm saying here's a picture of it. You can see it on there. We got it right there. So that's what Craig
But
is
when you
referring
put
to.
it in your hand, it's like air. It's
Well,
like it's so light.
So a couple things. Yeah, Craig. What I was more referring to is perhaps the bearing coupling feels more
Oh,
familiar.
absolutely.
Agreed that
But I think the cup is different. It's not.
well,
It's
it is
not run of the
different.
mill. It's not.
I mean, one thing worth knowing, and obviously I've gotten to know Ronan, Treacy, and Derek McMinn very, very well. The BHR was not a device that just sort of sprung out of the womb as a perfect final finish device, right? Derek and Ronan went through multiple iterations between 1989 and 1997, making minor changes in the implant to get to the BHR that ended up being clinically fairly successful. And Craig talked about it earlier, there was some combination of metallurgy and luck and other things perhaps, but right, the PolyMotion has gone through the very similar iterative which I think folks hopefully can understand that. So it's back to the clinical history. We have roughly 3 versions of the device that's starting back in 2014 or so. This has been a long project. As you all know, developing implants in any field of med tech, it's not like you just come out with the final version and it works perfectly. You have to do some iterative process because you never know how one little change in an implant. That's been one thing that I've learned kind of going from being a doc or an operating orthopedic surgeon to being in industry. You have to be very careful when you make changes in an instrument, right, or the feature of an implant. But top level, Craig, the first version of what we'll call the PolyMotion that now dates back to almost 2015 was actually a cross-linked polyethylene without vitamin E with the titanium coating, just plasma sprayed on there the way you would plasma spray onto a taper lock stem or something, right? It was a very, and they did they did about 100 of those. They followed them for 3 years. And of course they saw that the coating didn't stick very well. right after a few years. And again, the loosening rates were very low, but then they said, okay, this coating technology doesn't work. Let's go to a next process. So there was an iterative process of learning how to get titanium to stick to a piece of cross-linked polyethylene, that has been 12, 15, 13 years in the making. And so anyway, and then as far as the cones, Craig, the cones were designed, again, thinking about failure modes, to provide significant amount of initial implant stability, similar to how the way screws would. And of course, as you know, one of the early, we don't talk about it a lot, but one of the early failure modes of resurfacing was not only femoral neck fracture, but it was putting in a monoblock cobalt chrome cup that never got appropriately fixed into the acetabulum in the first place, right? Some of those cups would spin out early, right? So these Derek and Ronan have, 40 years of learnings around resurfacing that went into the device, which is what gives it the confidence. But anyway, that's sort of the clinical history of how it evolved. Didn't come out of the womb in this final version that you call, that looks, unique, et cetera. Now, there's one more part of the story that's very worth. Joe is sitting in Switzerland right now. There's a very well-known Swiss company called Mathys, Mathys, that has been making cups like this, with some features of this for many, many years with excellent
Decades.
clinical results. Yeah,
Yeah.
and again, the fact that it never came to America, is perhaps unfortunate, because a lot of surgeons in other countries, in Australia and Switzerland and Germany and others, have been using cups like this for 30 or 40 years with excellent clinical results. And the interesting thing is, because the modulus of elasticity of this polyethylene, right, this cup is so close to that of the native bone, there have been some nice papers published that show that over time, the bone behind the acetabulum actually responds better to a cup that has a modulus that's closer to that of even a titanium or a cobalt chrome cup. So there's a lot of sort of biomechanics and biology, Craig, that went into this development that, probably we won't have time to cover every bit of it on this podcast. But I guess the main point I want to make is this has gone through a similar iterative process where they made a couple changes, followed a bunch of patients, saw what, and so this, this kind of this final version, it's been a long time in the making, very similar to the way the GHR, and I would call it responsible implant development is what I call it, because, I think that is the way to do it. You have to do a few patients, like you said, you did your 20, saw how they did, right? And then, sort of in your first, in your initial BHR experience, it's been a similar iterative process here. But I agree, it's a different technique, but I'm hopeful the bearing surface feels familiar to people because it's something they've been using for a while.
And Craig, since you have been using it in the trial, you pointed out this difference in how the acetabular component feels, right? Even though the polyethylene is a polyethylene we might be used to, right? That spray titanium backing. And we used to, when I was in fellowship, we put in a lot of Mathys cups, and we used to call them, I used to call them ghost cups, because you'd see them on the x-ray and it looks like
cool.
a shadow of a cup, right?
It's very cool.
But are there other differences that you've noticed in the OR? Not stuff on paper, not stuff in the design aspect of it, but other aspects of this that you've noticed that are different? Is it when you compare it specifically to your experience with the Birmingham?
Fortunately, no. I mean, it looks really cool on the x-rays, but in terms of, at the end of the day, I guess my bias is it's hard to get a resurfacing cup in because the exposure is difficult.
Mm-hmm.
So I'd say it's the same. But fortunately, my PolyMotion patients look exactly like my BHR patients, which for me has been a good thing.
But Joe, Craig, back to the point, this is fun to discuss, in sort of real time on a podcast like this. This is part of what's made this fun, working, again, with someone who is formerly a mentor. When you give me feedback that, hey, your instruments don't work, I'm having trouble with them, we can rapidly iterate those. And we're actually in the process right now of making some changes to our instruments that we believe, back to your point around just, taking it up to a 30,000 foot view. I think it's some of the best work an implant company could do, in addition to developing new metal and plastic stuff that goes in people, is actually the instruments and learning in real time. Every time Craig did a case, and I was with Craig for a lot of cases, we would take notes on like tiny little things that were making the spikes difficult to prepare. And Craig, we haven't actually had a chance to show you these improvements yet, but we will very soon. that's one of the most gratifying things about this whole sort of clinician, CEO kind of thing is being able to make those changes rapidly and encourage our engineers to make, to make it easier. That's been a fun part of this whole journey that, I guess I never would have had, hadn't made the career switch. So,
Well, and let's talk a little bit about instrumentation and approach, and I'm going to focus a little bit on approach because obviously we're the Anterior Hip Foundation podcast, and Sharat, you specifically have, I think, referred to anterior approach resurfacing as, I think the phrase was synergy, not rivalry, specifically with the anterior approach. Tell me a little bit about what you mean by that.
what I mean, you asked me a question earlier, right? What problem are we trying to solve? I would ask the legion of highly experienced, knowledgeable, thoughtful clinicians, what problem was the anterior approach trying to solve back when it came, right? And if you think about those, it's all we're all thinking about the same thing. What we're thinking about is trying to preserve soft tissues. Well, why not also try to preserve bony tissues? And so, the reason I talk about synergy is the whole, at least, and I'm not an anterior approach guru by any stretch of the imagination. I learned from Craig how to do a good posterior approach, and I know that's heresy on this podcast. But I think we had a pretty good run doing that approach. Craig, I think you're still doing that in all your primary hits at the moment, and
Yeah.
I'd certainly let you do my hip any day of the week. So, Joe, but I mean, what I meant by that is often positioned as this debate that, well, resurfacing is somehow conceptually or religiously or whatever, ethically, or antithetical to resurfacing. That's not the case at all. If anterior hip surgery is all about maintaining muscular attachments and soft tissues, well, then why not extend that passion and belief for that to preserving the bony side of the anatomy as well, which we know is probably equally as important as the soft tissue. And it's a system, right? I mean, we were designed with soft tissues and bones to be able to, obtain with the nervous system as well, to be able to drive optimal mobility. That's what I mean by that. And so what's been fun about this whole thing is we have some anterior approach surgeons who are in our ID study, who are some of our key opinion leaders at JointMedica, and we listen to them hanging on every word because we know that if we want to make this thing successful, we need to make it successful in the hands of everybody. There are plenty of, yes, anterior approach surgery is whatever, 50 or 60, 55%, but there's another 40% of a pretty big market doing another approach. My passion as a leader of the company is to make it where everybody with any approach can come to the table and have a great experience. And that's what it's all about. And so, I'm happy to talk more about it, but that's what I mean when I say that, Joe, is the synergy is save the soft tissues and the bones, not just one or the other. So.
Well, and Craig, how about you? Where do you personally land on? Well, specifically, let's focus on anterior approach resurfacing. Is it something you're doing? Is it something you're watching? Or are you a skeptic of it?
So when I first started, it made sense to me because we were I was worried about the blood supply of the femoral head. So again, to your experience, I started thinking through, is this something that we should be doing a trochanteric flip osteotomy? Should we be doing it through a hardening approach to better preserve the blood supply of the femoral head? And then, of course, the resurfacing people from the UK were like, yeah, we already did that study. It doesn't make a difference. They looked at Harding's versus posterior, and there was no difference in femoral loosening. There was no difference in cup position. There were really no differences in outcomes, whether they were done through a Harding approach or whether they're done through a posterior approach. And I remember early on, I'm sure you know Michael Mont, great guy, outstanding surgeon. I watched him do a resurfacing with a Harding approach, an anterolateral, take off the anterior 30. And, he had good surgeons who've done a lot of them. And he did them no problem. So, in an age where people are routinely doing revisions anteriorly, I don't think doing resurfacing anteriorly is an issue at all. I think a good anterior surgeon is going to be able to do it. And someone who casually does anterior approaches is going to struggle. And I think the same thing through the posterior approach. I think it's a harder operation, but you get a skilled surgeon who's comfortable with the surgical approach. I don't think it's an issue at all.
And Joe, what we've seen, just real quick to kind of echo Craig's point, Mike is of course one of our study investigators. Thrilled to have him on our team as well. But what we've seen in the ID study is patients have done, have had similar recovery. It's similar, let's say early clinical result. agnostic of approach, and the anterior approach surgeons, have contributed to our understanding of how to make great instruments, as have the posterior approach surgeons. And so, we're incorporating all those learnings. We intentionally pick surgeons, let me say, for our study so that we would have a representative sample from all the different approaches. Because again, I firmly believe that we want to provide a great intraoperative experience for all surgeons, independent of what approach they're coming from
Mm.
to the hip.
Do you feel there's something specific that has to be true more so for anterior surgeons to feel comfortable adding resurfacing to their toolkit than posterior surgeons, or is it the same approach regardless?
Yes. um, I, at least, well, I think certainly for a posterior approach surgeon, talking to Derek, getting to know Ronan, I think when they started looking at, okay, I think they clearly recognize it's a more difficult operation. And when they started to teach other surgeons, they immediately looked at people who were doing revisions and who were doing complex things
Mm,
because they're good hip surgeons.
mm,
I think for me, the hardest thing when I'm trying to teach other people resurfacing, and even this is controversial, I, I feel like in my hands, I pretty much need to do a complete capsulotomy. And I think for a lot of posterior surgeons, they're not comfortable and familiar with how to release the anterior capsule.
mm.
So I think for me, I need to release that capsule 360 to be able to get the femur out of the way to expose the acetabulum and to resurface the head. I think if anything, anterior surgeons, all the time are releasing the posterior capsule. So if anything, it should almost be more natural for an anterior surgeon to be comfortable, because I think most anterior surgeons are probably doing anterior capsulectomy as the first part of their operation. And I think in selected cases, they're releasing the posterior capsules. I think they're comfortable doing that. Just a little harder when the femoral head and neck are in the way, you know?
Right. Yeah, and we've had Justin
Oh, go
Cobb
ahead.
on before. Yeah, and I'll give you a moment, Sharat. We've had Justin Cobb on before, and he's talked about his technique and demonstrated it nicely at some of the meetings, doing his resurfacing through an anterior approach. And he's doing a full circumferential capsulotomy as
Yeah.
well. Yeah,
Yeah. I
very
think
important
for me,
aspect of
that's
the
one of the,
operation.
I think it is, but it's interesting. I'm on this group chat, this World Hip Resurfacing chat, and it's always so interesting. For me, as much as I love going to meetings in the United States, I I personally learn a lot more when I go abroad. And it doesn't matter if it's English speaking South America, Asia. I always learn so much more because there's people who are thinking differently and doing different things. And I'm on this World Hip Resurfacing chat, and they're doing stuff that I wouldn't think would be compatible with good results. And these are folks doing stuff differently. And they're like, oh, you don't need to do a complete capsulotomy. I do XYZ. So again, I think there's always room for innovation. It's always fun to be around smart people who are passionate about something and try to learn as much about it. And as Gerard had said, innovate and make things better for our patients and for us.
Sharat, what did you want to add?
No, I was thinking about your question. I believe the question was, what are elements that are going to be, and I'm paraphrasing your words, but a little bit, but what are the elements that are going to be critical for anterior approach surgeons to, I think, adopt resurfacing was roughly the question you're asking. And I'm not an anterior approach surgeon, so I may not be the most qualified to, you may actually be better qualified to answer that than I am. But I guess it's the same belief that we talked about earlier about the synergy. It's a synergy, the same passion that comes from that, that those of you who are anterior approach surgeons believe it's a better mousetrap, a better way to get into the hip, a better way, you at least a lot, I presume you believe, better long-term function and better everything. I suppose you have to have that same belief that, well, there's some benefit to preserving bony tissues as well. If you don't believe that, then, it's probably not for you. But if you do believe with the same passion that the soft tissue treatments that you're employing in your standard hip replacements are beneficial, you have to have the same belief that the maintaining bony tissues is also going to have additional incremental benefit. That's what I think is going to be required for at least some segment of anterior surgeons to adopt this.
Hmm.
I mean, and I'll also say one more thing, and this is why it's fun, is we're spending a lot of time as a company thinking through from an instrumentation standpoint, what are some of the exact mouse traps, widgets we're going to need to be able to make it easy for you, as easy and pleasurable, I guess I would say, to do a resurfacing as to do your standard anterior total hip. And so I think that's the company part of it. That we've got to make instruments that where you come out and say, "Gosh, that was amazing. That was slick. I enjoy doing that." If that's not the case, then I don't think we've met the bar that needs to be met for the anterior
I
audience.
think I think if an anterior surgeon is able and comfortable doing an isolated cup revision through an anterior approach, I don't think they're gonna have an issue doing a resurfacing. I think it's a lot of the same skill set. Learning how
So,
to
Craig,
mobilize that femur and get that femur out of the way so you can get to the cup. I think it's a
Mhm.
lot of this. I feel like for me, it's a lot of the same skills
but the
is
one other
is
thing when you
learning how
want
to
on the
mobilize the
resurfacing
femur.
is getting that head around, be able to put that pin in the center. There probably is some technology as a company that we are working on it actively that makes that step easier because where that step goes away in a total, you don't have to find the center of a femoral neck doing a cup revision, right? But in a resurfacing, you've got to not only do what you eloquently described on the cup side, on the head side, you've got to figure out some way to help them get that guide pin right down the center of the neck so they don't end up with femoral sided complications. So I would add that one nuance that, in addition to the skill set, uh, my sense is we've got to solve that mousetrap, solve that problem as well on the femoral side for anterior
Well,
surgeons.
and as a self-described hip resurfacing troglodyte, I mean that's the whole operation, is my understanding, right? Is getting that pin in the exact right trajectory that you want, getting the position of your femoral component.
I think it's probably easier if you've never done it before. I think it's almost like doing, putting a sliding hip screw in. It's not that hard. I
Okay,
think most people who could figure out how to do like an anterior hip could figure out how to get that guide pin in the right spot. And again,
not
there's
necessarily the
nuance to it.
difficulty of it, but the importance of getting it correct.
Yeah, yeah. I don't maybe I feel like when we first learned it, we were really worried about femoral neck fractures, really
Mm,
worried. And
mm,
I feel like there's two basic axioms: avoid notching and avoid varus, and be respectful of the soft tissues. I think that's important as well. I think if you can do those three things, I think the risk of femoral neck fracture in general is going to be low. Now, I think through the IDE study, we've seen that there couldn't be some nuances with surgical technique and instrumentation that may make that rate low a little bit lower. But in general, I think if you avoid notching, avoid varus, and are respectful of soft tissues, uh, I think it's relatively easy to avoid that complication to get the femoral head in the right spot. It's not that
mm.
difficult.
Joe, the way I'd answer the question is it's one of those things, and I love thinking about like the cognitive burden of us, as kind of as a company leader now, and how do I reduce that for customers, right? It's one of those things you never had to think about it before when you're doing a total hip, and so it's just one of those, it's another added cognitive burden of just something that I don't have to think. So if I would agree with Craig, it's generally pretty easy. I would agree with the articulately described axioms he mentioned, but when you're first learning it if you've never had to think about it before, it's one of those things like, gosh, I hate thinking about this. Can you make it easier for me to not have to think that? Maybe I would, as sort of a person talking to customers, that's the way I would articulate it slightly. Is
Mm.
that if I could take that cognitive burden down, that's going to be a benefit to the new learner who's already learning a couple of other new things. And the other piece I would say, Joe, that I would fully agree with Craig on this. When we first were doing resurfacing back in the mid 2000s, it was femoral neck, because all the early complications were related to femoral neck fractures, right? We didn't see the delayed complications later. The
Metal
cup
fixed
position,
that. We stopped worrying about neck fractures almost completely.
Mm.
I would agree, but Craig, but if you remember when you went to
There
the
had to
first
be
few
some
meetings,
benefit to it. Oh yeah,
the early
absolutely.
you hated having it's like having a periprosthetic
Yeah.
calcar fracture with stem. I mean, I'm sure Joe, when you were learning anterior hips, that was a very common thing that happened to people, right? When they were learning in their first 100 cases, they'd have a lot of sort of calcar issues. Once you get rid of that, if we can make that go away, I'd say it's a similar dynamic in the resurfacing that cup
I would
position is equally
yeah.
important, but yeah, the femoral size may be overstated a bit.
Mm.
The other thing I think that really helped me, and I'm pretty sure either McMinn or Treacy or one of those folks helped me understand this. If you think about resurfacing the neck, and then you want to centralize that stem on the neck, kind of ignore the head and focus on trying to be in the center of the neck. It almost always gets you in the right spot because it doesn't look right. When you're first doing it, you're like, whoa, that's not right. I'm taking a bunch of bone inferiorly. I'm just skimming it on the top. That's not right. And then you throw the drill on there and you're like, oh, that does look right. It's right centered on the neck. So
Yeah.
that I would say would be the technical tips, like avoid varus, avoid notching, and think about trying to resurface the neck and being centralized on the neck. I think that's one of the things that really helped me from a technical perspective.
And Joe, as we're looking at sort of technology to augment this, PSI, patient-specific instruments, has taken a beating, a bludgeoning over the last 25 years, whether it's knees or whatever. I believe as a company person now that a PSI guide for the femoral resurfacing side could be a really excellent application for that kind of technology to make that step very easy. Again, agnostic of approach. You put the guide, we've tested some of this in the company. You put the guide on, you put the pin down the center and then cognitive burden gone, right? And so these are some of the things we're thinking through as a company. Back to Craig's point around, well, the common podium argument is hard to do. That's why I don't do it. Well, if I can take that objection away, I've made a even a more compelling argument to learn the operation. So,
well, so you guys have been really generous with your time. I've got a few closing questions, and I don't want to take up more time than I requested of you. But you've brought up so many great points today that it feels like we could have 2 or 3 more episodes just talking about some of the issues you've raised. But Craig, I want to start with you. If we were to do this interview again, say in 10 years, what do you think we would be talking about as the biggest misconception about resurfacing right now?
That's a good question. I hope what we're going to be talking about, and I'm not sure if this answers the question, is that the PolyMotion device got rid of the metal failures and brought the complication rate of conventional hip replacement and resurfacing to the same level.
Mm.
I think the complications still might be a little bit different. I honestly believe the anatomic head size lowers the risk of dislocation. And I hope we'd be talking about, again, that I think that getting rid of metal equalize the complication rate, and that hip resurfacing skill or that hip resurfacing offers a higher level of function. I think that's what we'd be talking about. I hope that's what we're talking about.
Sharat, how about you?
Yeah, I mean, I would echo everything Craig said. I hope we're talking about with an open mind that there are several excellent solutions for primary hip arthritis in different patient populations, and that our profession openly embraces that. Yes, there are, the armamentarium should be broad, and if someone chooses to do total hips in 100% of their people, that's fine. But they also shouldn't be chastising the person who's taking the time to learn a different procedure and demonstrating that the results can be excellent at scale. Again, not in 1% of the population, but in 10% or 15 or 20%. I hope we're talking about that. I also hope we're talking, this is maybe a slight variant on the themes that Craig, I hope we talk about how innovation in orthopedics used to be difficult, but our company sort of demonstrated how to get through. And that's something we haven't touched on at all. And, in this podcast, which I think is a fascinating topic that I'd love to talk about with more of my surgeon colleagues. What we're trying to do at JointMedica is really leverage our surgeon key opinion leaders and working closely on the because again, regulatory affairs, globally has become a very challenging, both for the regulators and for companies, right? And I can tell you,
And the
doing this,
surgeons.
but Craig, I guess what I'd say is I don't think, and I don't mean this with any, this is not disparaging in any way. I don't think we spend enough time, Joe and Craig, at our academic meetings talking about how surgeons can help implant companies drive innovation. We spend more time talking about just our own arena. I hope we talk more about, well, hey, JointMedica is a company that actually showed how to bring together surgeons, regulators, engineers together to innovate. Because again, let's be honest about it. The innovation in our field over the last 20 years probably hasn't been as dramatic as perhaps it's been in cardiology, and other areas. I mean, if you look at the cardiology, space, right? I mean, think about transcatheter aortic valve replacements and electrophysiology, your defibrillator, cardioverters. I'd like to hope we're talking about that. This company demonstrated how that partnership can help accelerate innovation cycles in the implant space in orthopedics. Again, I think that has slowed, and I think the empirical, review of the market would demonstrate that. So those are the themes I hope we're talking about in addition to the clinical side of things.
Mm. Craig, if you could have a conversation with the junior attending who was maybe just starting to do these, back in 2007, um, what would you tell yourself about where this is going to go, and something you'd wish you knew now, or you wish you knew then that you know now?
I have no idea. Um, Again, I'm probably not answering your question. I think the smart things that I did was, I think people go to a course and they don't have something on the schedule. And then there's this delay between kind of being taught it and trying it yourself.
Mm.
So I think like if you're going to go to a course and learn how to do something, I think you kind of need to like do them close to each other, and you got to like keep at it and give yourself, you know, the ability to get through some of the learning curve before kind of making a decision.
Mm. Sharat, what does it mean to you to be building the next generation of this procedure that you first watched Craig perform?
Yeah, and I mean, divorcing from, say, the procedure itself, what I find most gratifying, and I hope we end up with more former clinician leaders, in implant companies, right, and in pharma companies, and in healthcare policy. It's just been a real career privilege to have had a career, having been fortunate to train with folks like Craig, who are as well respected, and having learned from them, and to be able to take that legitimate clinical experience, right, and then using that to drive the decision cycle within a company every single day. That I think there's some pretty interesting opportunity there. Again, back to what I'm very passionate about the partnership between surgeons and companies that could be augmented. It's a privilege really to be able to work with former mentors and colleagues like Craig and Mike and Ronan and others, to be able to be translating the insights at such a rapid velocity into the development cycle in a company. It's truly a privilege, and again, like I say, I hope that I take that privilege very seriously, and the responsibility of it, and it's very meaningful to be able to work that they have the trust in me to put these implants in their patients and to work with us so closely. It's this responsibility I take very, very seriously, and it's incredibly meaningful to be able to do
Mm.
things like that. And I hope it can inspire more, clinicians and docs to maybe spend more time helping to innovate in the healthcare industry, because I think broad segments of our industry need more folks who practice medicine driving the innovation. I think we have just a lot of innovation that's driven by maybe folks that haven't had a chance to be in the clinic and take care of patients, and that is such an important element if you're going to innovate, whether it's digital health products or instruments or whatever it is, right? If you've never been in the trenches, it's hard to know what docs and patients need. So I take that privilege it's very meaningful.
Craig, last question for you. Any advice to our younger listeners about how to sort through fad from, maybe the next big revolution?
Yeah, I think it's hard. I think, yeah, I mean, I think, as we talked about in the beginning, I got interested in resurfacing because I felt like I'm in an academic center. Someone here should learn it. And I think maybe that's what you do. If you're lucky enough to be in a group where there's a couple folks doing adult reconstruction, I think it's nice to help develop someone as a specialist in some little niche thing. Patellofemoral arthroplasty, partial knee replacement, managing periprosthetic infection, doing hip resurfacing. I think if you're lucky enough to be in that situation, we have a couple of surgeons who are working together, work together to help someone develop a clinical expertise. Because at the end of the day, there's definitely something to be said for the more that you do something, you get better at it. You understand the indications better. You understand the nuances of the operation. So like when I was a resident out at Harborview, the traumatologists each had their own little niche thing, and they would send each other the pelons, the calcs, the pelvises, the acetabulum. They kind of sorted it out amongst themselves, or I guess maybe the chair did, and said, okay, I want you to really develop some expertise in this. Um, I think that's a model that works. And if you have that ability, either at, again, an academic center, or if you're in a private practice group where there's a couple of folks who have the opportunity to practice together, pick something and really try to become an expert in it. Um, I think it gives you the ability to take better care of patients. Academically, it gives you opportunities for research to be able to talk about things intelligently. At the end of the day, not everything you try, you're going to like. Not everything you try, you're going to think is going to be good. And I guess the biggest one is don't do stuff just because that's what you were taught. So like the biggest example for me is I was on the plane. I was with my daughter. She's 7, and we were on the plane, and I always grab a couple of magazines. I still like having paper magazines. I'm 56. I still like paper, and I still like reading it. I grabbed my general bone and joint surgery, and the 1 versus 2 stage exchange paper was in that edition. And I was really proud reading that. I mean, I remember enrolling my first patient in that study and being terrified that I was doing something bad. I remember I did my first resurfacing, being terrified I was doing something bad, making this giant incision. The patient's going to do terrible. And I think we all need to challenge our own beliefs and then study them, because I think there's a lot of things we do out of tradition and not maybe as many things that we do because we have good evidence to support doing those things. So I think we all need to challenge our own beliefs. Like we were talking about earlier, like travel, do a traveling fellowship like Sharat did, try to learn about something else, because there are new ways to do things and think about things that can improve not only our patient's quality of life, but your own as a surgeon. I always say that, like 1 stage exchange improved my quality of life. Like not having to worry about scheduling 2 surgeries, not having to worry about checking labs every week, not having to worry if the spacer's going to dislocate or break or something terrible is going to happen. And again, I was really nervous doing those first cases. I think we all just need to like take a step back and challenge ourselves and say, really, why am I doing this? And study it and learn about it.
Hmm. Well, gentlemen, I really appreciate you joining me today on the podcast. And from a clinical perspective, from a med tech perspective, it was really fantastic to hear your thoughts. And I'm really excited to see what you're able to do with PolyMotion and with JointMedica as a bigger company. So thank you so much for joining me today on the
Thanks for having
AHF
us.
podcast.
It was fun.
Thank you,
It was
Joe.
fun.
It's an honor to be appreciate the opportunity and hearing our story. Thank you so much.
Thank you for joining me for this episode of the AHF podcast. As always, please take a moment to like and subscribe so we can keep the lights on and keep sharing great content and conversations just like this. Please also drop any topic ideas or feedback in the comments below. You can find the AHF podcast on Apple Podcasts, Spotify, or in any of your favorite podcast apps, as well as in video form on YouTube/@Anterior Hip Foundation, all one word. Episodes of the AHF podcast come out on Fridays. I'm your host, Joe Schwab, asking you to keep those hips happy, healthy, and maybe resurfaced.